Welcome everyone to today's National Neonatal POCUS Collaborative webinar. I'm Kelly Rausch and I'll be our moderator today. Before we start, just some general housekeeping items to make note of. The chat is disabled for the audience, but the moderators may send out general announcements via this chat feature. Please use the Q&A feature to post questions, and we will answer those during our Q&A panel session after the talk. This webinar is being recorded and will be uploaded to the collaborative website, neopocuscollab.com. Now on to our main talk. Our guest speaker today is the Dr. Maky Fraga. Dr. Fraga is a professor of pediatrics at University of Pennsylvania, a neonatologist at the Children's Hospital of Philadelphia, the chair of the Pediatric and Neonatal Ultrasound Committee for the Society of Critical Care Medicine, and the chair of the National Neonatal POCUS Collaborative. She is truly a founder in the field of neonatal point-of-care ultrasound and truly needs no further introduction. We are honored to have her kick off this season of the Collaborative's webinar series. And now, Dr. Fraga, please take it away.
All right, thank you so much, Kelly, for the introduction. Let me share my screen. Let's see if everyone can see this. Yes, does it look good? I hope so. So, okay, so thank you, Kelly, again, and thank you everyone for joining this webinar and for spending this hour with us. This is really the first webinar of this academic year, which is actually the third academic year since the creation of the National Collaborative back in May 2023. And I just want to thank everyone who has subscribed, first of all, and joined the collaborative, as well as all the people that have been working with us in all the many different committees that we have. So it really has been a wonderful experience and a continuously growing network. So I was asked today by our two leaders in point-of-care ultrasound education, who are Karina Lawrence from Denver and Cara Beth Carr from UNC, to open our monthly sessions presenting our last, the two recent publications in the Journal of Perinatology from last month, focusing on training guidelines and quality assurance processes. However, my main goal for this talk, I would say, as the physician, is really the need I have to share and pass on like pragmatic knowledge, right? Like the practical experience-based insights that guide me through this work and passing on with one another. So, and apart from this, I have nothing else to disclose. So this is the outline for this talk. This is what I really would like to convey. I would like to review, first of all, the historical background that has shaped today's work. I would like to highlight the importance of understanding the context when planning ultrasound integration so we can effectively address challenges. And also, I want to illustrate how learners training in point-of-care ultrasound across the world benefit from shared external support, fostering a collaborative global community. And this is really my ultimate goal, right? If we can ever have an open access, huge database that we can all share, de-identify images, that everyone can have access and do research on, that would be my dream. Okay, so to start, let me pass on, there you go. To review just a little bit of history, I really like this part. The ultrasound was already being used during the First World War to detect the presence of submarines. It was actually this doctor, Karl Dussig, who was an Austrian neurologist, when in 1942, he became the pioneer of medical ultrasound. He invented this machine that you see in the left-hand side of the screen, that transmitted ultrasound beams through the skull to diagnose brain tumors. And he called this hyperphonography. So this was the first published work on medical diagnostic ultrasound. So you can see also a newspaper on the right-hand side of the screen that it is from 1950. And that was the official, as you can see, the official newspaper of the MIT undergraduate saying, and I'm gonna read this, that acoustic lab work on tumor technique, ultrasonic may give new brain diagnosis. And you can see that they describe a new approach approach to the problem of detection and diagnosing brain tumors being investigated. And the project is entitled The Detection of Intracranial Pathology by Ultrasound. And what it is interesting, it says this project is still in its infancy and may take years of research before it is clinically used. And I just want to highlight that because I will come to that a little bit later. Just remember that. So from the mid-60s onwards, really the advent of commercially available systems allowed the wider dissemination of ultrasound, right? The technical advances of at this time actually led to the rapid growth in the applications to which ultrasound could be used for, bringing it much closer to us, definitely. And it has been slowly blended into clinical practice, and as we all know, and this is in part due to the fact that nowadays, graduating students from medical schools, as you know, are trained to view ultrasound as the new stethoscope or as an extension of the physical exam. And really, this development did require the medical education community to embrace and incorporate point-of-care ultrasound throughout residency and fellowship curriculums. So we know that point-of-care ultrasound can fill gaps in our knowledge and can help us identify pathology, characterize disease processes, and make clinical decisions, right? Notably, I want to say this, that evidence supporting the efficacy of point-of-care ultrasound on improving patient outcomes is scarce. And this is likely due to the complexity of designing clinical outcome studies for a diagnostic tool, because this is just a diagnostic tool. And because of the adoption of point-of-care ultrasound as a standard of care in those clinical circumstances in which it's most useful, right? And I think this is a very clear explanation of why this is lacking. So those clinical situations where really medical management can be tailored to provide an individualized approach. And this is what we all want nowadays in clinical practice. So let's review the pace of point-of-care ultrasound integration in medical education so we can understand better what led us to do what we are doing. So back in 2014, as you can see here in the New England Journal of Medicine, there was this article published, was the first one that actually speaks by itself, saying, stop listening and look, right? So this article describes how undergrad medical education was starting to change at that time with the incorporation of point-of-care ultrasound teaching in very few schools in the US. Now in Canada in 2016, this is a cross-sectional study, survey that reported that 60% at that time of medical schools had some sort of point-of-care ultrasound teaching in their curriculums. So 2 years later, this is in the US, there was this cross-sectional national survey conducted that at that time said that 28% of the medical schools that were surveyed at that time have a formal ultrasound curriculum. And these continue to evolve with many different papers describing, for example, this one, the rising tide of POCUS in medical education, and being described as an essential skill set for undergraduate and graduate medical students, right? So this is the most recent data. This is from now, I think it's a couple of months ago that was published. It's another survey that was sent to 155 medical schools in the US, and 130 responded. And it said that 66% nowadays of these schools have an approved formal point-of-care ultrasound curriculum for their medical students. And most of them with required training during the first year and second years. And then they have elective training during the third and the fourth year. So this medical education eventually, right, translates into implementation and integration into clinical practice, right? So in my mind, this is what the journey looks like, right? It's been, 11 years since the first New England Journal of Medicine paper. And since then, we have seen, I would say, like incremental, but intermittent progress in the use of POCUS, right? So, and this is the use of a diagnostic tool that has an impact definitely on patient care, on patients' lives, right? So if you look at the x-axis here, it represents time. So this really reminds me of the very well-known data showing the average delay between a discovery that offers clear and unquestionable benefit to patients and its adoption as a standard of care at the bedside. As you may remember, the delay is on average 17 years. And there is no question about how it benefits patients, right? In very specific clinical situations, as you know, like this paper came out many years ago. So also many years ago, when I started to get trained in point-of-care ultrasound, really very quickly, I realized and I understood why this matters. This clip's not playing, let's see. Yeah, why this matters and why this improves patient care, right? We know that POCUS has been demonstrated to improve diagnostic accuracy and to also shorten time to diagnosis. And, you know, I don't think anyone would argue that diagnosing a tamponade, a cardiac tamponade quickly and performing a pericardiocentesis under ultrasound guidance doesn't improve patient outcome and patient safety, right? I don't think there is a discussion around this. So, and this is the reason why many protocols have been recently developed advocating for the use of point-of-care ultrasound in critical situations, right? Such as the crashing infant protocol that was published by Yasser in Canada, the SAFE-R algorithm for the suddenly decompensated infant in the NICU that was published by Jorgen, Nadia, and Daniele De Luca, right? So with all this evidence of clinical benefit, right, the question at that time for me was how to adjust education and how to frame training to really fully implement and integrate point-of-care ultrasound and do it safely, right? So, but at that time, which was probably 11 years ago, I only realized that our neonatal point-of-care ultrasound community was notoriously fragmented. We were all working in silos. And my question was how we could bring this application and standardize this practice in neonatology. So at that time, my option was to work with others who were ahead of me. So what happened, and this is part of the historical background, I joined the Society of Critical Care Medicine, which wasn't my society and not even represented neonatology. But I started to train people. I started to teach at these courses, at their courses. And at that time, I was able to introduce neonatal content in their courses and change the course names to critical care ultrasound, pediatric, and neonatal point-of-care ultrasound. And, you know, we have probably taught a couple of thousands of these courses throughout these years, and that we have been offering them everywhere, not only at CHOP, but all throughout the US, as well as in Europe, in Japan, everywhere. We've been everywhere. But we know that training people is not sufficient. That's for sure. And this is unpublished data, but we know that when we do these 2-day courses on whatever we are trying to teach, the uptake is not going to be that great. So probably in all these diagnostic ultrasound applications, maybe less than 10% of the people that we train are going to take this to the bedside, to their home institutions, and provide care using ultrasound. So it doesn't seem to be that straightforward. And we are aware of many existing barriers, right? But we keep offering this everywhere. Definitely is not enough. So what to do? What we did, we started to work together with international friends because, you know, we share this community. We do share, our needs are really not different and our patients are not different either. So we started to work with many people in Europe, many different societies. We collaborated with writing international guidelines for pediatric critical care and neonatology together, because working together made a lot of sense to push this forward in our specialty. So we published this through the European Society for Pediatric and Neonatal Intensive Care. So all this previous work, I think it made possible that years ago, we were able to reach out to the American Academy of Pediatrics, specifically to the Committee on Fetus and Newborn, and also join the section of radiology through the AAP, and work together in writing this clinical and this technical report defining the use of POCUS in the NICU, specifically in the NICU, for both diagnostic and procedural purposes. So, and really this pushed us into delineating the steps for program development, right? Because if we were going to use this and apply this at the bedside, well, we definitely needed to develop a program for that. So first we had to define what our domains were as neonatologists, so meaning what were the diseases or the clinical scenarios we were going to use ultrasound for, and where was this potentially going to impact patient care. Then we needed to decide how to train people to become competent in bedside practice, right? In bedside ultrasound. And finally, we had to define how to direct this over time and spread it out in an attempt to standardize training curriculums. But we couldn't keep working in silos, any longer. It was unproductive and it was inefficient. So 2 years ago, that was May 2023, Shazia Bomba and I decided to start this collaborative, really with the dream of getting the neonatal community together to create a national team and transition from parallel efforts to an integrated collaboration. And really simply started to reach out to people, inviting them to join us, knowing that we would encounter barriers, but we got a lot of people together, and it was very, very important at that time. And we kept, working together over these past 2 years. But, in order to start some good work, we really needed to know where we are or we were at this time. So this recently happened. So Kate Miller and Will Corder sent out a national survey that included 99 academic centers with, neonatal fellowships, of which 79 responded. So we really had a good response. And as you can see, right now, most of these centers have a dedicated ultrasound machine and are using POCUS, as you can see right here. But what was striking to me was was the fact that 83, if you look at the large academic programs, 83% of them have already some sort of point of care ultrasound training for fellows, right? Without yet having a national curriculum. So everyone is teaching this the way they think is best, right? So this is the problem, a lack of a standardized training, a lack of certification and credentialing. So we thought it was important to pay attention to how efficiently educate future POCUS practitioners and really how to assess competence and how to minimize potential harm, right? But recommended, we got together and we by this publishing these papers, we are recommending some training guidelines and some QA framework. So what we did, we developed this structured and systematic consensus approach. We selected like an expert panel from the National Neonatal POCUS Collaborative. We did perform a literature review from the past 10 years, and we achieved consensus, using majority vote among panelists. So we then here define the scope of practice in neonatology. So the guidelines were organized into 5 different subsections corresponding to the key areas of applications, right? Which is the heart, the lungs, brain, abdomen, and procedural ultrasound. So within each section, we define both basic and advanced point of care ultrasound applications, and assigning each of them, as you can see, a level of evidence. And really this list of basic POCUS application is intended to probably serve as a foundational framework for developing a core neonatal POCUS curriculum. So these basic applications really can typically be mastered by learners during fellowship, neonatal fellowship. And also, as I said before, we came up with more advanced applications, which, probably they require more specialist training to achieve proficiency. And they are here in this table. So we had many, many discussions, not only on training needs, for which learning objectives are required as a first step, but also on accreditation standards and, and competency assessment. So taking as a framework, the competencies domains that were described a while ago by Banner, but they're really very, very nicely explained in this paper cited here, which is from this year, which are called I-AIM. That means, indications, as you can see in the graph, image acquisition, interpretation, and medical decision making. So we do acknowledge that, no one size fits all. Not surprisingly, the plateau of each learner's learning curve is unique to them, right? Like that makes sense. But nonetheless, group learning curve data can be helpful for educators that, like us, that we are tasked with this POCUS curriculum planning, for example. So there is another recent work by Brennick that assessed the acquisition of the 3 psychomotor skills related to individual components of image quality, which are depth, gain, and tomographic axis. And they found, not surprisingly, that cardiac point-of-care ultrasound presented the longest learning curve. So scan numbers are always used as a surrogate for competence, right? But these numbers should really be viewed as expert recommendations rather than strict requirements. I really want to be very careful when developing structures, that maybe are not easy and they don't facilitate implementation of something that I know helps patients, right? So we really want to make this the easiest possible without compromising safety, for sure. So as you know, multiple educational institutions, scientific societies, or expert groups recommend learners complete like a minimum number of scans. So, and this really varies widely depending on what society. So initially, back in 2001, the ACGME and the American Board of Emergency Medicine, they established they requested 150 scans as a graduation standard for emergency medicine residents. In 2016, the American College of Emergency Physicians, ACEP, changed it and recommended that each learner should at least perform 25 to 50 quality review examinations in a particular application. In addition, of course, to some observed structured clinical examinations. So, as a whole, I would say that evidence regarding the association of scan numbers and competency and diagnostic accuracy is inconsistent, right? Which is not surprising given that each individual will have their own unique learning curve. But nonetheless, I think scan target numbers are mandated within a training program for sure. So what we decided to do, we follow what is being already established, and we decided to recommend 25 to 50 studies for each diagnostic application, except for cardiac. So for cardiac, we are requiring or suggesting to get more studies, meaning 75 studies for cardiac POCUS, because we wanted to remain consistent with the recently published recommendations from the American Society of Echocardiography on cardiac point-of-care ultrasound, for which Shazia Gombal is part also of the working group. We also propose a quality assurance process, and this is really to ensure the safety of patients and also healthcare institutions. And, by regularly schedule a QA image review, but definitely, to maintain patient safety, ongoing education on point-of-care ultrasound, practitioners is vital, right? So by scheduling these QA reviews, that helps, first of all, to improve our own POCUS skills, but also gives the opportunity to learn from others, right? So this is what we propose after defining the neonatal POCUS applications. We propose education starting with a 2-day introductory course, and then continue education, having a fellow and faculty curriculum with peer review rounds and feedback and a skills assessment. This should go also be accompanied by patient assessment and review, which is a QA, definitely a standardized documentation, and having an internal weekly review with provider feedback, as well as monthly review with other specialties to get other insights, such as radiology and cardiology. And then also we propose a clinical workflow, right? How to integrate this into Epic and how to document scans. All this leads to institutional credentialing, right? After getting the scan numbers that are proposed and accepted by the institution, which in this case is 25 to 50, at least this is true at CHOP, for each diagnostic application, except that we change now for cardiac point-of-care ultrasound, as I mentioned before, to become credentialed and be able to obtain privileges at the institutions you practice. We decided that for procedural point-of-care ultrasound, we do not need extra privileging just because as neonatologists, we already have privileges to perform procedures. So really adding as an adjunct ultrasound to help ourselves doesn't require extra privileges, although it does require some supervised and observed learning, right? And also re-credentialing should be also incorporated every 2 years, as well as review process for quality assurance. Also, I just wanted to say that last year, Belinda Chan has described this proposed workflow that I was just mentioning in this paper that is very, very nicely explained if you want to go back and take a look at that. And she also added all the CPT codes for billing to make them easily available for everyone. You know, currently, Karina Lawrence is working on point-of-care ultrasound, like one-pager infographics. This is an example on different topics that will become available through Neo reviews. So really lots of educational ongoing efforts going on. So, but also I want to say, and I'm almost done with this talk, that maybe we are already too late for this, right? And this is an article that was published a month ago in the New York Times, saying that, you know, your AI radiologist will not be with you soon. And if you can see here on this on the right-hand side, say people should stop training radiologists now, because it was just completely obvious that within 5 years, AI would outperform humans in this field. So, you know, maybe all this effort, we are already arriving late, but still it's something that needs to be done. And I just really hope to transform these slow, intermittent steps into like a rapid, like this growth curve that quickly, you know, reaches a stable plateau, because really our patients will not wait 17 years for us to catch up with them. So thank you. And now we are gonna open this up for discussion, so we can have an open discussions and questions. Thank you very much.
Thank you so much, Dr. Fraga, for such a wonderful and engaging talk this afternoon. So again, we'll move on to our Q&A expert panel discussion, and please put any questions into the Q&A and I'll relay them to the panelists. So joining Dr. Fraga today, we have 3 esteemed members of the Neonatal POCUS Collaborative, Dr. Groves, Giuliano, and Singh. Dr. Alan Groves is a neonatologist and professor of pediatrics at Dell Medical School at the University of Texas at Austin. He is the mastermind behind the well-known NICUPOCUS.com website and has a primary research interest in neonatal hemodynamics. Dr. Courtney Giuliano is a neonatologist and associate professor of pediatrics at Mount Sinai Icahn School of Medicine. She is assistant chief in the Division of Newborn Medicine, vice chair of clinical innovation, and the co-lead for the NICU POCUS program at her home institution. And Dr. Yogan Singh is a neonatologist and professor at UC Davis. He is the chair and founder of the European Society of Pediatric and Neonatal Intensive Care POCUS Working Group and the chair of their cardiovascular dynamics section. Thank you everyone for being with us today. The first question that we have is, what was the single biggest hurdle that each of you encountered in establishing your POCUS program?
Yeah, mine was actually what I mentioned in my talk was just all working in different silos, right? And not working together. I found at that time that we were not making progress that way, right? That we really had to join forces. And then, you know, that globally, I mean, At an institutional level, we all have different hurdles. So I'm gonna let Yogan and Courtney speak for them, but mine was not that hard at my institution because I was lucky enough to have other specialties already way ahead of me. And they've done this job before, I really needed to put my efforts there. And that was pediatric critical care and emergency medicine, which I follow. But I don't know, Yogan and Courtney.
And that's a great question, Maky. I think it depends what time are you talking about. So because we're coming a long way, this is a journey we started many years back. So if you ask this question, say about 10 years back, that point, lack of the good guidelines, lack of the governance structure was a big deal at that point. That's the biggest hurdle at that point. But with time, we developed with nice guidelines, nice clinical governance structure. Those things are in place now. So after that is more about the people recognize is there, the lack of the resources in terms of the machines, which is, again, in the last couple of years, that's not an issue. A lack of the trained people. If you want to develop a program, you need a person who's trained, formally trained, who can train others with a good quality and with the quality assurance. So I think this is a very dynamic and mobile and very dynamic question, dynamic answer to this one as well. So I think today, if you want to develop a program, you get fantastic resources around, including from our own collaborative from in the US. So machines are there, as Maky showed from the recent survey. Trained people, most people do have. Now it's more about the finding the time and the resources for the people to train, both for the trainers and the trainees, how to incorporate into the training programs now.
Yeah, I think it's evolved so much in a way. We started, almost 10 years ago. So there were pluses and minuses to that. I think lack of a framework was tough in a way, but also allowed for a little more liberal and kind of slow incremental progress in our own institution, a little bit of a grassroots kind of start. And so for us, I think it's been evolving into much more structure over time, holding ourselves accountable for the QA part of things, and really like the competencies and credentialing of the trainees. And I do think coming to a shared understanding, I think we had trainees who were eager, but then having to balance that with like, you have to put in the time, you have to complete the coursework and then the number of scans and submit them in the way that they can all be reviewed and sort of evolving along that path from the beginning when Alan and I sort of started a little bit more freelance 10 years ago.
I guess I would I think echo each of those comments and say, and rather than asking about the biggest hurdle, the most important hurdle is the one that's directly in front of you. But it's also nice to try and predict the subsequent hurdles as much as you can to try and get ahead of them. So I agree, over the last 25 years that I've been doing this, it was in sequence. The biggest problem was the lack of guidelines, and then it was the lack of training, and then it was the lack of hardware. Currently, it's the lack of either middleware or experienced people to proctor during the scan. And the more of those things we can try and predict 1 or 2 steps ahead, that can accelerate how quickly we can get this to the bedside. I think for most of us now, even in units that are doing quite a lot of POCUS, the biggest obstacle is protected time for the learner and the trainer, because for a procedural application, you need to have a baby that needs the procedure and somebody that can teach it and somebody that can learn it, all happening to be free at the same time. That's really hard to make happen. We ended up getting some grant funding to pay for a vascular access nurse as additional staff member to accelerate the training, and that certainly made a big difference to us. So yes, certainly trying to get protected time as much as possible.
Thank you. So building off of those answers, the next question we have is, how does a program build training course if there is no one officially credentialed at that unit?
Who wants to start? So can you repeat the question? How the program starts if there is no one credentialed?
Yeah, so how does a program build a training course if no one is officially
build.
credentialed within that unit?
Yeah, so we always get that question, right? But we always say that most likely there will be someone in the institution who has experience and can help you. So my personal experience, I was the first one to get credentialed in the NICU, right? But I trained with the PICU guys and I trained with the emergency medicine guys. And then I was the first one and I started to train other people. So I would say that is most likely available to you. If someone else wants to say.
I agree, Maky. I think if there's no program in any of the institutions or smaller units in the hospital, there's no trained personnel there, I think there other resources are there. So it's more about not working the silo, getting like right in front, like talking to the radiologist, talking to cardiologist, to the ER people, because they will be resources who will be more than happy. They will be happy to help you, explaining what they want to achieve really, explaining the goals of the program and asking for the help. I think that might be really important. Secondly, also with the technology these days, once you get the in-house support from the other departments, then other resources are also there. Again, like say, just like our focus collaborative, they do have the monthly sessions, monthly programs, learning from the different other cases as well. Attending a course, someone like definitely still need to have program directly in that hospital. Somebody need to take the lead, even there's a no trained person. Someone needs who can take the initiative and initially get himself or herself trained so that they can go on the course at this collaboration, take the lead for the discussions and lead the program development. And then they can be online, like imaging interpretation, helping, having a mentor even we at a distance, and we do support, like definitely their centers are there in the different countries. We support them and we help in training people there. We join their programs on a like say monthly basis and we train them that way as well. So resources are there. It's more of a looking around what is available in the hospital and what can be done locally, regionally, and what can be done further beyond that.
I see Dr. Groves has shared something with us.
Yeah, I think in 2025, it's hard to believe that anybody's working in a building where nobody does any point of care ultrasound. I think if you're in a very small level 2 NICU, that's possible. But much more likely somebody in your PICU, somebody in your emergency medicine department, your pediatric or adult emergency medicine department, you maybe have a PIC team. There are lots of other people who have something here. This is where I get to really play the old man card, having tried to set up POCUS programs in, I think, 5 different institutions now. I've made a lot of mistakes, and the mistake I've made most frequently is trying to do too much too soon, trying to train too many different people to do too many different indications, and you end up with nobody achieving anything. I really like Jay Kim's paper in healthmanagement.org, where he talks about really narrowing things down to 1 or 2 high yield applications, get a couple of successes through and act on that. And the structure that we've used to talk about that whenever Maky and Courtney and Yogan have run some workshops at PAS is everybody asks this question of where to start, but there isn't a generic answer to that question of where to start. It's specific to where you were working, what your pain points are, what your own team can do, what your neighbors and associated units can do, how much time you have, what hardware you have, what sim equipment you can get. More and more, I think the answer is vascular access, and vascular access is a nice place to start because it's a pain point for all of us, and because there's almost certainly somebody in your building already using POCUS for vascular access. Is it a bit different in a 600-gram baby? It is, but then maybe that's not the place to start. Maybe you want to start in some 4 or 5 kilo babies. Thanks to the return of syphilis, we always have a kid in our NICU that needs a 10-day course of antibiotics, and they're often 3 or 4 kilos, and that's a great place to start doing some POCUS vascular access, for example. But it's different in each place, but overall, I think the answer is ask for help.
Yeah, and to echo Alan's point about every place being different, we actually are ending with vascular access because it was sort of the thing we felt least comfortable with extrapolating out of more background in hemodynamics and other training. So, but we have a vast team and they are more than willing to sort of come and partner with us and teach our fellows that skill. But I agree, I think start somewhere is good advice and build out from there. In our own unit, we started mostly with umbilical line kind of assessments as just a quick sort of procedural adjunct. And we still don't have, I think Maky showed that basic and advanced list, included in our curriculum are some of those advanced skills. We don't have the expectation that everybody learn them, but we outsource those a lot. Like we have an IBD center that does a lot of ultrasound in kids. So they come and help do a little bit of that more advanced abdominal teaching and work from there.
Excellent. Thanks so much, everyone. The next question we have is, how do you see AI advances incorporated into the ultrasound machines affecting neonatologist training? And should we be training POCUS without AI help, or should we embrace it in all the capacity of the machines to interpret the images acquired at the bedside? My
personal feeling is we should keep a human in the loop for all of AI training and applications, but potentially it can enhance our skills and ability to use it.
I agree, Courtney, especially when it comes to neonates. I think still, given the complexity, and especially like with the dynamics and small structures, still I think we are far from adults, from the bigger children. I think the data set which is going in for the machine learning in the AI is mostly coming from the adults. So at the moment, I think first step will come in the more adult side, which are already there, right? Like in the many indications are there, including the neonates is coming our way, like simply like ejection fraction, which in real time with the bigger probes is available. And similar to B lines and adults, like bigger kids, this available. So I think AI is our friend. It will help us in interpretation, help in like a screening tool. But given the high heart rate, given the small structures for any single organ, I think still, I agree with Courtney, we need to keep the human in the loop. Somebody need to see, is the AI screening, is it good enough or not? And making the mistake. It'll be really fantastic tool, but it will need a little careful eye. Somebody needs to keep an eye, especially for the tiny neonates.
All right, our next question. Are there any specific online courses recommended by the NeoPOCUS Collab like MedMastery or SonoSim?
There are tons of them courses around, but I will not recommend one over another one. So I think that's totally individual people with the feedback and everything. But still,
I think they ask of online, Jürgen. Online, that's the question?
Yeah, that's the
That was
online,
the
but a lot of
question.
people provide some, but still, I think as a part of the POCUS collaborative and we have been training these courses for many years now, I still say it should be at least hybrid, if not purely in person. So that's why even for the guidelines, whether with the guidelines what Maky showed, our collaborative guidelines or the SP guidelines, or be going back, even the other echocardiography guidelines, what we said really should be a 2-day in person. Some lectures can be done online, but still they lack the more interaction. This is a very hands-on skill. So everything cannot be done online, or it will not be done optimally. So as a experts or as a people doing for these many years, I think we started this course in 2009, and since then I can tell still doing online, you can gain some knowledge, gain some experience, but it will not replace the hands-on skill what we learn in person. So simulators can be great, can be helpful again in person, can be models, can be real patients. There are different tools are there, but online is a great resource, but will not replace the hands-on, especially the hands-on in person. And there are different online courses are there. Somebody needs, we definitely can advise a couple of them, but I will not recommend one over another. And most of us are involved in different online courses as well. So I think we do have our own courses, but I don't think it'll be fair to say, no, that's the best one, that's a good one.
Yeah, I agree with you. And the only thing I'm going to add is that probably online courses or whatever, is maybe for a little more advanced, not at the beginning when you are learning the skill to acquire the image, but it may be helpful in teaching more like image interpretation, probably. But I agree with you.
Our next two questions are about under-resourced areas. So the first question is, can POCUS training address care needs in under-resourced community NICUs where lack of access to pediatric cardiologists is a challenge? And will it take a whole generation of neonatologists to have large-scale, national-scale reach?
I think that's a great question, Kelly, and I love this question. I think if you ask me, and again, we train the different countries in different settings, the limited resource setting. If you ask me, POCUS is more helpful, especially in those settings, than more like the cardiac POCUS. If you're in a big center, like in the CHOP in UC Davis or somewhere else in bigger centers, you can get an echo done very quickly. Yeah, it may not be for the pericardiocentesis, or may not be for the tamponade. It may still take some time, but still get an echo done. Same with the other resources, there many people are there. But if you're in the community, even the X-rays take a long time. You're suspecting intensive pneumothorax, you're suspecting a cardiac tamponade, or even the line positions. Can you use the UVC line? And the X-rays take a half an hour, 30, 40 minutes. I think there is the maximum use where you can save time, resources, and actually save life in those conditions. And at some point, we all can be limited resource setting our settings as well. Like our X-ray person may take a long time, or they may be busy. So it's really defining the limited resource setting, including in the high income countries. We had the resource setting, transport setting, in the back of the ambulance. So I think their focus become even more powerful, and both diagnostic and procedure in those settings, really. And that has been demonstrated by many our colleagues working in India and Africa, and they find it very useful there when they're getting an X-ray, getting more restorative formal echo is not only time-consuming, takes time, but also can be very expensive. But those are different settings. That's why it's really important to define what are the indications of the different settings as well.
I don't think we should back away from the fact that it is, while additionally valuable in the lower resource settings, it's also even harder to learn in the more low resource settings. I think it's a real challenge. I've heard a bunch of people talking about a global health and neonatal POCUS collaboration. I'm not sure. I don't know if anybody's really got that over the line yet. If any of the panel have got experience in that, I would be keen to hear how it's going. But I think that's a really valuable, that will be really valuable once we get there. The only thing I want to just comment on is that in general, the hardest thing with ultrasound of all types is the interpretation more than the acquisition. So one system that worked very well for us, actually, when I started at Sinai, was that I was able to do targeted neonatal echo and credentialed for that, but with a store and forward model such that the cardiologist could review my scans in near real time. And the wireless connectivity and range of platforms available now, I think, does give us some more imaginative solutions to this, that other than for vascular access and for procedural applications where it's less clear cut. But if you're wanting to make any other diagnosis, particularly screening for structural congenital heart disease, for example, somebody acquiring the images and then somebody else remotely reporting them has got, I think, will get us over the finishing line quicker than trying to get all those people at the remote settings trained in how to interpret a full.
I agree, Alan. I think the training in those limited resource settings is pretty hard, very hard. Finding the resources, there may not be any person for many miles, and maybe one or two people in the whole small country or districts in those regions will be really hard, really tough. But equally, those centers, those setups are joining hands with regional or local resources, may not be in the same country, may different country. I know some centers, like including my good friends in India, they're running these programs where they train many people from many other countries. They run this training program where people have some online, some hands-on, and then people get this experience. So a lot is happening outside the Western world, outside the US and Europe, that part as well. As I said, this is a very powerful tool in those settings. And people are taking initiatives. They're trying to help those communities as well. It's hard, it's tough.
We are trying a little bit. I can't say we've gotten it anywhere across the finish line, but in terms of more global training, and also just outsourcing some of our training to affiliate institutions, because we have a year-long sort of Zoom didactic curriculum that we can kind of allow others to access. So it's been sort of 2 years in the making, even for the global health part of things, but there's an affiliation between our institution and an international site. And we kind of tried to train multiple people and that fell flat. So now we have more of just a train the trainers type of approach, where 2 of their sort of consistent neonatal providers are embarking on our online curriculum, but it is partnered with regular trips down there. I know their machine, and sort of coupling that with many hands-on sessions. And they do have an acquisition storage system that I gained access to, so I can review images remotely with that team. So it's a model that also, like, we've sort of tried to work with one of our health system affiliates, a smaller level 3 NICU, to see if that's something that can kind of propagate the skill a little bit. Again, starting with some small application and trying to build out from there.
That's great work, Courtney. Thank you.
Next question for our panel is, how would we have easy access to POCUS Collab experts for any training, clinical, technical questions, etc.?
So we do offer office hours monthly. I think, Karina, we're starting, we don't have them this month, but starting next month. So, which is an open forum for anyone who wants to join and bring up any questions, discussions, share any information, as long as it is de-identified. Yeah. So that's open to everyone. And also we are reachable by email, right? And also the collaborative is open to anyone and everyone who wants to join. You can join a committee. We have educational committee, research, guidelines, credentialing, and social media. So everyone is welcome.
And you'll hopefully find, I think, that anybody that's been involved in these things truly want to be collaborative. We've all experienced the pain of getting this started. None of us, I suspect, on the call, on the panel, are as far ahead with POCUS as we thought we would be or hoped we would be. I'm certainly not. So we're all still on that journey too, just maybe a year or 2 ahead. The series of talks that the ONTPD coordinated about how to set up a POCUS program, I thought was very helpful. If you just Google ONTPD on YouTube, you will see Maky's lovely face on the first of the 4 talks, and they are a really nice run through for that. We have set up the office hours, though I have to say it still ends up mostly feeling like it's a presentation and then some Q&A. It doesn't mostly end up being a, hey, we're just going to sit here and people can jump on and ask us things. I do wonder, and people have touched on this already, at some point I suspect we might want to do true image review collab, of course, with de-identified images. That's what the Iowa Center are doing for their TNE training. They provide that training in person in Iowa on targeted neonatal echo, but they have their morning image review sessions open to people more broadly to both look at the images and discuss intervention based on the images. Again, it just takes a lot of time and effort to set these things up. I can pretty much guarantee you that nobody in this meeting has protected time to do any of those things. We're all trying to make time to do those things, but nobody's bought out 20% of my salary for me to be able to do that, and it's the same, I suspect, for everybody else. So we're trying to get those things, but I think keep getting in touch with the collab and let us know what would be most helpful, because the whole point is we've set up these, Maky has set up these structures because we want them to be as helpful for everybody that we can.
And
I
also,
agree, but Maky.
Yeah, I was going to add, sorry, John, we meet yearly at PAS. So every year for everyone to come as well.
Yeah. No, I agree with Maky and Ellen, what they said clearly, but one more just point to add, in addition to what has been discussed already, we are very accessible. We are happy to help. Yes, we are limited time, but we are happy to give some advice or even the mentoring with our limited time. So we do mentor some centers who are all developing the programs, helping our colleagues really. So we are approachable. Contact us via email, anything, whatever we can do. Yes, we are definitely resources restrained as well with the time, but we'll do our best. We'll do our best to help. This is a very collective, collaborative efforts we're trying to pull together, all of us.
Thank you so much for all of the speakers and panelists for this wonderful discussion, and thank you for joining us today. Join us for our next webinar, where we will have guest speaker Dr. Yasser Al-Saeed, who will be teaching us about POCUS for neck. You can register using the QR code on the screen or by visiting our website. In the chat, you will see the link to the Neo POCUS Collab website, where you can also find this webinar along with all of our prior webinars. Thank you, and we will see you all next month.
Thank you, everyone.
Thank you, everyone.
Yeah,
Have a good day. Bye-bye.